Welcome back, everybody, to what is our final session of our summit this year. And it is our 1 p.m. session with Dr. Scott Adams on the role of exercise therapy in the cancer journey. I will note Dr. Adams pre-recorded because they're a little bit under the weather, but are so dedicated that they will actually be here for the coaching question and answer. So I wanted to share that. Thank you for Dr. Adams for being here. Dr. Scott Adams is a physiologist and a scientist with over 15 years of experience delivering and testing the effects of exercise-based interventions for people living with and after cancer. In addition to his scientific work, Scott has founded and led cancer rehabilitation and multifaceted biopsychosocial support services in hospital and community-based settings. He has witnessed the power of exercise in improving the lives of people with and after cancer and is ready to help you retake control of your energy and life. We thank you very much for being here with us, Dr. Adams, and I hand you the virtual floor.
Welcome, everyone. Thank you to CRAN and the My Colorectal Cancer Summit organizers for having me. My name is Scott Adams. I'm the founder and CEO of Cancer Fatigue Services, Canada's first physician-led precision medicine practice for people living with cancer-related fatigue. Today, I want to talk about something that I believe will fundamentally change how we think about cancer treatment. It's not a drug, it's exercise. Over the next 45 minutes, I'm going to walk through what the evidence actually says, and more importantly, what you can do with it. Whether you're a coach, a patient or survivor, a caregiver, or a clinician. I want to start with a headline. Last year, a study was published in the New England Journal of Medicine, one of the most prestigious medical journals in the world, and it showed for the first time in a gold standard clinical trial that exercise improves cancer survival. This was the challenge trial. It was led by doctors Carrie Kernier and Christopher Booth. It was 17 years in the making. It enrolled 889 patients across 55 hospitals in 6 different countries. The results? Patients who followed a structured exercise program after completing chemotherapy for colon cancer had a 28% lower risk of their cancer coming back or developing a new cancer, and a 37% lower risk of dying. Look at this comparison. The absolute survival benefit of the exercise program was roughly 7 to 8%. That's comparable, and in some cases exceeds the benefits we see from some of the approved adjuvant chemotherapy drugs. Let that sink in. Exercise is not a lifestyle suggestion, it's a treatment. And now we have the highest standard of evidence showing its effects. Now, I know some of you are thinking, that sounds great, but I'm not an athlete, or the people that you work with are telling you, hey, I can barely get off the couch. Here's the thing. The challenge trial, the participants in the challenge trial were not athletes. They were everyday people. The average age was about 60. They chose their own activities. I think walking was the most common, but it also included things like resistance training, swimming, playing pickleball. The goal was to complete about 2.5 hours of moderate activity per week. That's about 30 minutes a day, over 5 days a week. But they were given 3 years to build up to it. The key was that they had support. A kinesiologist or an exercise physiologist worked with each participant to set goals, check in, and adjust the plan. And that's what made it work. This is not about becoming a marathon runner. It's about moving more with the right support over time. Now, let me show you what that looks like in the real world. I want you to meet someone. This is Maria. She's 62 years old, and she's a composite character, built from many of the people I've worked with over the years. But her story is real. Maria has just been diagnosed with stage 3 colon cancer. She's about to have surgery, then chemotherapy. She's scared. She's exhausted just from the diagnostic process. And like most newly diagnosed people, she has no idea whether she's allowed to exercise or whether she should just rest. Maria could be your client. She could be your mother, your sister, your friend. She could be you. So over the next 30 minutes, we're going to walk with Maria through every stage of her treatment, before surgery, during chemo, after treatment. And I'm going to show you what the evidence says, what exercise can do at each step, and how to actually make it happen in the real world. Before we dive into Maria's journey, I want to give you the big picture. Exercise doesn't do just one thing. It operates virtually across every domain of cancer survivorship. And this wheel summarizes what we know from the most comprehensive meta-analysis or grouping of many studies of exercise in colorectal cancer. So this meta-analysis included 19 randomized controlled trials with over 1,200 participants, and it was published by Singh and colleagues in 2020. Starting with fitness, there were large improvements in aerobic capacity, and this was probably the strongest finding from this meta-analysis. They showed that fatigue was improved, with supervised programs showing the best results. Quality of life was improved, especially with programs that lasted 12 or more weeks. Mental health was improved. Depression was reduced by nearly half a standard deviation, and we call that clinically significant, meaning it's a large enough change that people notice. Body composition was improved. There was reductions in body fat, and importantly, reduced C-reactive protein, which is a marker of systemic inflammation. And finally, and now layering in the challenge trial, we see that exercise also has a potent impact on improving survival. So the point I want you to take away from this slide is exercise isn't a single outcome intervention. It touches everything. And that means it's relevant across every stage of the cancer journey. Now, the first question that comes up from survivors, from caregivers, from oncologists is this safe? The answer is unequivocally yes. Across the same 19 randomized trials with over 1,200 people enrolled in them, there was zero difference in the serious adverse event risk between the exercise group and the usual care group. And this finding held true whether people were exercising before surgery, during chemotherapy, or after treatment. It held true for supervised and unsupervised programs, and it held true for aerobic, exercise, resistance training, and combined programs. Adherence was also high. There was an average of 86% of the total prescribed sessions were completed. Dropout was low, only around 12%. And roughly 40% or 4 in 10 eligible people agreed to participate, which is pretty strong for an exercise trial. And importantly, this holds true whether we're focused on the pre-surgery period, during chemotherapy, or in the post-treatment phase. So let's get into Maria's story. Like I was saying before, Maria has just been diagnosed. She has about 3 to 4 weeks before her surgery is scheduled. Right now, she's feeling helpless. Like everything is happening to her. Is there something she could do to use this time to get ready for her surgery? Would it actually help her? That's what prehabilitation is. Preparing your body for the stress of a surgery, the same way that some athletes prepare for competitions. Here's what the evidence tells us about prehabilitation for colorectal cancer. The Prehab trial, published in 2023, is the single largest multimodal prehab clinical trial to date. There were 251 patients across multiple countries, Participants in the study received 4 weeks of supervised high-intensity exercise, nutrition optimization, and psychological support before their surgery. The result? Medical complications were reduced by 52%. Burkle and colleagues published another study in 2022 focused specifically on high-risk patients, older adults with lower baseline levels of fitness. Their community-based prehab program took place over 3 to 4 weeks. It improved VO2 peak, or their aerobic fitness, by 1.6 milliliters per kilogram of body weight per minute, and their walking distance improved by 27 meters. Not only that, it reduced their complication rates significantly. Remember, we're talking just 3 to 4 weeks of intervention here. An older study by Gillis and colleagues back in 2014 compared prehab to rehab. So the same program, but one group did it before surgery and one group did it after surgery. The prehab group recovered their baseline walking capacity by 8 weeks post-surgery at a time that the rehab-only group still hadn't recovered. But now we need to be balanced. The Phys-Surg trial is the largest perioperative exercise study ever done. It enrolled 668 participants, and they found no effect on self-assessed recovery. But here's the important nuance. The intervention was low intensity, mostly unsupervised walking and breathing exercises. So the take-home message across all of these trials is clear: intensity and supervision matter. So what does prehab look like? And I want to start at the end. The key insight here is the fittest people have the fewest complications, and even modest improvements in fitness before surgery can make a meaningful difference in how someone recovers. You don't need to be an athlete. You just need to be fitter on the day of your surgery than you were on the day of your diagnosis. So Maria has 4 weeks to prep for her surgery. Her plan involves 3 to 5 days a week, or on 3 to 5 days a week. Her plan involves walking for 30 minutes at a moderate pace. She should be able to talk but not sing, walking this quickly. 2 to 3 days a week, she does resistance exercise, targeting the major muscle groups. This can be body weight, resistance bands, light weights, things like that. 2 days a week are dedicated to light activity or recovery. And alongside exercise, she works on the nutrition, with the goal of intaking 1.5 grams of protein per kilogram of body weight per day, which helps protect her muscle mass through the surgery. And she has access to psychological support to help with things like anxiety management, doing breathing exercises, and the mental preparation for the procedure. And then this program is progressed gradually over the entire 4-week period. Now, here's a practical question. Where does Maria go to get this support? Not everyone needs the same level of help, and not everyone has access to the same resources. And I think about this as like a 3-tiered model. Tier 1 is self-management. This is where motivated people with guidance from coaches or peers follow home-based walking and exercise programs using evidence-based resources like Cancer Society guidelines, exercise handouts, step counters, apps, and things. And this works really well for people who are already somewhat active and have lower surgical risk. Tier 2 is more along the lines of a community-based cancer exercise program. There are incredible programs like Prehab RX or Wellspring that offer structured group exercise or personal exercise coaching services with professional oversight in a community setting. There's accountability, there's social support, and there's someone making sure that the program is appropriate. And this is really ideal for people who need great structure and motivation. Tier 3 is medically supervised exercise. And this is what we do here at our clinic at Cancer Fatigue Services, where we use cardiopulmonary exercise testing, or CPET, to precisely measure a person's capacity, and then we create individualized exercise prescriptions based on those results. And this is critical, especially for high-risk patients, for those with lower baseline levels of fitness, for those with multiple comorbidities, or with complex surgical plans, where we need to know exactly how much physiological reserve they have. And the message here is really important. It is not that tier 2 is better than tier 1 or 3 better than 2. It is that the right tier depends on the person. Coaches play a critical role in tier 1 and in helping patients navigate to tiers 2 and tiers 3 when they need more support. So now Maria has recovered from her surgery. She's starting FOLFOX, which is a combination chemotherapy regime that is standard for stage 3 colon cancer. Problem is, she's exhausted, she's nausea, her hands and feet are starting to tingle from the oxaliplatin, and her oncologist says, take it easy, rest when you need to. And the rest advice is really well intentioned. But the evidence tells us something more nuanced. Let me walk you through what we know about exercise during chemotherapy for colorectal cancer. So Van Valpen and colleagues in 2016 studied supervised exercise during adjuvant chemotherapy. The exercise group experienced almost no decline in their aerobic fitness, a drop of just 0.3 mils of oxygen, compared to a drop of 2.4 mils of oxygen in the control group. That's a meaningful difference. They also saw a trend towards higher chemotherapy completion rates, 94% versus 76%. It wasn't statistically significant, and because this was a small trial, but it's worth paying attention to early signals like this. Zimmer and colleagues conducted the only randomized trial in metastatic colorectal cancer patients. And this is important because most trials exclude people living with metastatic disease. They found that 8 weeks of multimodal exercise, aerobic resistance, and balance training counteracted the progression of chemotherapy-induced peripheral neuropathy. Chemotherapy-induced peripheral neuropathy is one of the most debilitating side effects of oxaliplatin, and there's currently no approved drug treatment for it. Exercise may be one of our best tools. Lin and colleagues showed that supervised exercise during adjuvant chemotherapy improved global quality of life using the QLQ C30 questionnaire, reduced fatigue, and improved functional walking capacity. And here's a really important subgroup finding from the Singh meta-analysis that we showed earlier. The aerobic exercise improvements were actually largest when exercise was conducted during chemotherapy, not before or after. However, the hypothesis that exercise during chemotherapy will improve fitness more needs to be tested versus looking at whether it's just preventing the loss, and that's where we see the between group differences. I think there was a lot of variability in that study that they noticed, meaning there was some studies that showed very little impact and some studies that showed a lot of impact. So there's more research that needs to be done here. Now, this is one of the most important slides in the presentation, especially for coaches. The people you are coaching may ask you, when should I exercise before my chemo cycle? I feel terrible on some days and okay on others. And here's how I like to think about it. The typical FOLFOX cycle is 14 days. Day 1 is infusion day. Days 1 through 3 are the hardest. The acute side effects hit, nausea, fatigue, sometimes pain. During this window, the goal is gentle movement only. Short, slow walks, some light stretching, even just getting up and moving around the house. The key message here is don't stop moving entirely, but don't necessarily be pushing yourself. Days 4 through 7 are the recovery window. Most people start to feel better here, And this is where we can gradually return to moderate exercise, say like a 20-minute walk at a brisker pace, maybe even some light resistance work. But days 8 through 14 are the strongest window. This is when most people feel closest to their baseline, and this is the time to do full exercise sessions. Longer walks, proper resistance training, maybe some cycling. Take advantage of this window before the next treatment cycle starts. The most important principle here is something is always better than nothing. Even on the worst chemo day, a 10-minute walk around the block counts. And on the good days, we really capitalize on that energy. So for coaches, this slide is your conversation guide. Help the people you're working with map their own good days and bad days. Every cycle is a little different, but most people develop a predictable pattern within 2 to 3 cycles. So let me reapply the three-tier model to the chemotherapy context because the needs are different. Tier 1, in the self-managed phase, where coaching support is often the backbone during chemotherapy. Most people are at home between infusions. A coach can help with setting daily step goals, check-in calls, text messages, and most importantly, normalizing the bad days. The Smart Pace trial by Van Blarigan, apologies for the pronunciation, showed that Fitbit monitoring plus text message reminders is feasible, acceptable, and valued by colorectal cancer survivors, and coaches can play exactly into this role. Community exercise or cancer exercise programs provide structure, social connection during the time that can feel really isolating. Hubbard and colleagues adapted a cardiac rehab program for colorectal patients or colorectal cancer patients during chemotherapy and achieved an 88% adherence rate without dropouts. That tells us the model works. We just need more programs like it. And finally, medically supervised exercise becomes critical for specific patients during chemo. If someone has pre-existing cardiac risk, if they're developing significant neuropathy, if they're severely conditioned, frail, these are situations where you need a more evidence-based approach, CPET-based assessments to know what intensity is safe and effective. And at Cancer Fatigue Services, we can precisely measure these thresholds and adjust prescriptions accordingly to make sure that treatments progress safely. So now, Maria has rung the bell. She's done with chemo. Everyone congratulates her. But here's what people don't talk about. The bell is not the finish line. For many people, it's actually one of the hardest moments because the structure of the treatment is gone. The regular appointments, the nursing support, the sense that someone is regularly watching, looking out for them, it all stops. Maria's deconditioned. She's probably gained some weight. She's fatigued. She has residual neuropathy in her hands and feet, and she's anxious. Every ache, every twinge makes her wonder if her cancer's coming back. And this is where the long-term game begins. This is where exercise may matter most. The post-treatment evidence is the deepest and the most consistent body of literature we have for exercise in people with colorectal cancer. Seller and colleagues showed that 12 weeks of supervised aerobic and resistance exercise produced meaningful improvements across the board. Aerobic fitness, upper body strength, lower body strength. Another study used an 8-week supervised lumbopelvic exercise program focused on core stability. The effects were actually striking. Large reductions in fatigue, improved quality of life, and almost an 80-meter improvement in their 6-minute walk test. That's an 80-meter improvement in just 8 weeks. Another study tested a pragmatic lifestyle intervention, exercise plus dietary counseling, and saw reduced body fat and improved fitness in just 12 weeks. And Brown's phase 2 trial demonstrated a dose response effect. Patients who exercised more than 300 minutes versus 150 minutes per week saw greater improvements in fitness and body composition. So more is better, but perhaps up to a point. We don't need to turn into marathoners here. Now, let's come back to the challenge trial, because this is the study that changes the conversation from exercise is good for you to exercise is a cancer treatment. With the 889 patients who were enrolled, all had completed surgery and adjuvant chemotherapy for high-risk stage 2 or stage 3 colon cancer. They were randomized to either a 3-year structured exercise program or to receive standard health education materials. The exercise program was pretty simple. The goal was to increase aerobic exercise by at least 10 MET hours per week above baseline. That translates to roughly 2.5 hours of moderate intensity activity. So brisk walking, cycling, swimming, whatever each person preferred. Each person was paired with a kinesiologist or a physiologist who checked in regularly to help set goals and provide accountability. At 5 years, disease-free survival was 80.3% in the exercise group versus 73.9% in the control group. That's a 6.4% absolute difference. The hazard ratio for disease-free survival showed that there was a 28% risk reduction. And for overall survival, there was a 37% risk reduction. To put that into context, that's 7 to 8% absolute survival benefit is the same, within the same range as what we see from adding oxaliplatin to the 5-FU chemotherapy protocol. Exercise is not just complementary to treatment, it is treatment. So what does this look like for Maria in her everyday life, 6 months, a year, 2 years after treatment? Here's a sample week. Monday, a 30-minute brisk walk. Tuesday, resistance training, bodyweight exercises, bands or light weights, targeting the major muscle groups. Wednesday, active recovery, maybe some yoga, gentle stretching, maybe a light stroll. Thursday, another 30-minute walk or bike ride. Friday, resistance training again. The weekend, some sort of active leisure activity, gardening, swimming, walking with a friend. So the total is about 150 to 200 minutes per week, and that aligns directly with what the challenge trial prescribed. The critical message here is you don't have to start here. Maria didn't get to this level overnight. She built up gradually. She started with 10-minute walks, then 15-minute walks, then 20. The challenge program gave participants 3 years to reach their target. So the emphasis is on consistency, on progression, not on hitting a specific number in week 1. Start where you are, build from there, and stick with it. After treatment is where the tears may take on their most important role because this is the longest phase of survivorship. People may live 10, 20, 30 years after their diagnosis, so exercise needs to become a lifelong habit. So in tier 1, this is where coaches have the most impact. Post-treatment, daily touch points shift from the healthcare system to the community. Coaches can provide the accountability, the encouragement, and the goal setting that helps keep people active. Pinto and colleagues showed that a telephone-based coaching intervention improved physical activity behavior and physical function. That's exactly what cancer coaches can do. Community exercise programs like Wellspring or PrehabRx offer exercise classes or one-on-one supervision. Or there are also, I believe, some new programs offered in gym settings that are ideal for this transition from recovery into living well. They provide structure, expertise, social connection. In the group exercise setting, it helps reduce isolation, which is a real and unappreciated problem in cancer survivorship. And in tier 3, The medically supervised assessment is one of the most valuable at this particular transition point when someone is finishing their treatment and needs a new baseline. So at Cancer Fatigue Services, we do a full CPET, body composition analysis, metabolic assessment. We actually assess all 10 treatable causes of cancer-related fatigue. So it's really a whole person treatment approach. But then for many people, we're prescribing precision exercise interventions targeting the specific mechanisms of impairment that we pick up on during the testing. So then as the person stabilizes, they can graduate from that tier 3 back to tier 2, hopefully to tier 1 for maintenance. And then as necessary, people can pop back into tier 2 or tier 3 for periodic reassessment or if new complications arise. I think the key concept here is that the tiers shouldn't be treated as a hierarchy, they're a spectrum. And people should be encouraged to move between them based on their needs. And this slide is the single framework I want you to take away for today. Across the top, the 3 tiers of support. Down the side, the 3 phases of treatment. Each cell tells you what to do, where to go, and who it's best for. I'm not going to read every cell. You can study this after the session, but I want you to notice the pattern. Every cell has something in it. There is no phase of treatment and no tier of support where the answer is do nothing. So whether it's a home-based walking program with a coach checking in by text, a community exercise group at Wellspring, a CPAP-based prescription at CFS, there's always an option, regardless of what phase in the journey you're in. The question is never, should this person exercise? The question is always, what kind of support does this person need right now to exercise safely and effectively? And that's the question I want you to carry forward. Now, for the coaches in the audience, this next slide is for you specifically. I want to give you some confidence about when your role is to support someone directly and when your role is to connect them to medical supervision. These are the flags. If you notice any of these in a client, it doesn't mean that something is necessarily wrong. It could, but it doesn't mean something is necessarily wrong. But it definitely means this person may benefit from a higher tier of support. Your job as a coach is not to diagnose any of these. It's to notice them. And when you do, to say, hey, I think you could benefit from talking to someone who specializes in this. Can I help connect you with them? That's a referral. It's a bridge. It's one of the most valuable things that cancer coaches can do. So I want to emphasize this point with one more, admittedly somewhat chaotic visual. The point here is people don't stay in one tier forever. The cancer journey is not a straight line, and neither is the exercise support pathway. Just as an example walkthrough, at diagnosis, a person may step up to tier 3 for prehab, especially if they're older, more deconditioned, facing a more complex surgery. During chemo, they may stay at tier 2 or tier 3 for their exercise sessions with tier 1 coaching running alongside for their daily support and accountability. After treatment, they may step down, first to an assessment at tier 3, then to a structured program at tier 2, then gradually to tier 1 for self-management, with periodic check-ins happening at the higher tiers. And this is the most important part. If something changes, a recurrence, a new complication, a significant life event that disrupts routine, they can always step back up. The stairway goes both ways. This is meant to be more of a, safety net, not a one-way street. Coaches are at every level, helping people navigate through these transitions. Now I want to shift gears and speak directly to the cancer coaches in the audience. Everything I've shown you today, the evidence, the tiers, Maria's journey, it all depends on one thing: someone starting the conversation. someone being there to ask the questions, someone being there when it's hard. That's you. And let me give you some practical tools to help support that. So here it is. The single most powerful thing you can do as a coach is to ask this one question. What kind of exercise or physical activity are you doing right now? And what would you like to be doing? That's it. The question does three things at once. First, it normalizes the conversation. It tells the person that exercise or physical activity is expected, not forbidden. Second, it meets them where they are. There's no judgment, there's no prescription. And third, it opens up the space for goal setting. What would you like to be doing invites aspiration. And from there, you follow up. What's getting in the way? Maybe it's fatigue, fear, lack of information, no access to a program. Each of those requires a different solution. What did you enjoy before a diagnosis? This reconnects them to their identity before cancer. Would it help to have someone in your corner as you get back into it? This is the coaching relationship in a single sentence. So here you're not prescribing exercise. You're opening a door. And for many people, that door has been closed since the day of their diagnosis. So here are 5 things you can do tomorrow, literally tomorrow. First, you can normalize movement at every stage. When someone you're working with says, hey, my oncologist told me to rest, you can say, rest is important, but so is gentle movement. The research across 19 clinical trials shows that exercise during cancer treatment is safe and beneficial. You're not actually contradicting the oncologist, you're adding evidence-based nuance. Next, help set small, achievable goals. Not exercise for 30 minutes a day right off the block. Start with, can you walk to the end of your driveway and back? Then build from there. Remember, the challenge trial gave people 3 years to reach their target. Patience is part of the prescription. Another key activity here is to celebrate the consistency over the intensity. Don't ask, how hard did you go? Ask, how many days this week did you move? Across all the clinical trials, adherence, simply showing up and doing what was prescribed, was the strongest predictor of benefit. The median in those trials was 86%. You don't need to be performing heroics here. Being consistent is what matters. It's also really important to know when to refer. We've just covered those flags. Keep the list handy. When in doubt, connect the person to a higher tier of support. You're not losing a client per se. You're being a responsible professional. And finally, be people's accountability partner. A weekly text, a phone call, a shared step count. The Smart Pace trial showed that something as simple as text messaging reminders made people or had a meaningful impact on people's behavior. You don't need a gym or a program. You need that relationship. So let me tell you where Maria is now. She's 18 months after her last chemotherapy treatment. She walks 5 days a week, usually in her neighborhood, sometimes at the mall when the weather's bad. She does resistance training twice a week with a group at her local wellspring. She started volunteering as a peer supporter, helping newly diagnosed patients navigate the same journey she went through. She's not the same person she was at diagnosis. She's stronger. Not because she was an athlete, not because she had some genetic advantage, but because she had the right type of support at the right time. A prehab program before her surgery, adapted exercise during chemo, precision assessment after treatment. and a coach who kept her accountable when she wanted to give up. And that's really what this talks about. It's not exercise as an abstract concept. It's exercise as a system of support at every stage, at every level that helps real people live longer and live better. 3 takeaways here. If you remember nothing else from this talk, remember these. Exercise is not optional, it is a treatment. The challenge trial we don't actually prove things in science, but the challenge trial provided robust evidence, level 1 tier evidence, showing that exercise caused significant reductions in the risk of recurrence and the risk of death. This trial was published in one of the most prestigious scientific journals in the world. Next, the right support at the right time can make all the difference. Self-management, community-based exercise, medically supervised options, they all have a role in this continuum, and patients move between them. The question is never whether to exercise, it's what kind of support does this person need right now? And lastly, you coaches are the connective tissue. You normalize the conversation, you hold people accountable, you bridge the gap between the healthcare system and patients' quality of life. You are essential to making this work at scale. Here are some resources for you to follow up on. If you're working with someone who needs medically supervised, particularly CPET, prescription-based, precision-based exercise prescription, you're certainly welcome to refer them to us at Cancer Fatigue Services. We're in Toronto, but we actually work with patients across the country. We're from, I think, Halifax to Vancouver. For community-based programs, there are physical exercise support services available at Wellspring, online exercise support services available with organizations like PrehabRx. These are excellent options and available across Canada. And then the tier 1 level of support can be supported through different evidence-based guidelines, through some of these organizations. And I'll leave my contact information at the end. If you're looking for more information about any tier of support that we didn't have time to highlight today, please feel free to get in touch and we can definitely connect you with them. I want to leave you with one thought. Exercise is the most underutilized treatment in cancer care. We need to change that, one conversation at a time. Every person in the audience has the power to start this conversation, whether you're a coach, a patient or survivor, a caregiver, or a clinician. You can be the person who says, have you thought about exercise? Can I help you get started? That's one conversation that could completely change someone's trajectory. It could be the difference between deconditioning and recovery, between isolation and community, between recurrence and survival. Thank you so much for your time today. For the organizers of this event, I'm happy to take some questions.
Thank you so very much, Dr. Adams, for your presentation and, of course, your dedication to educating our coaches and viewers on what is one of the most discussed topics for sure in oncology today. Your presentation was wonderful, and we thank you sincerely for being here and, again, for supporting cancer patients with the work that you do. To our viewers, for our final thank you and goodbye, my colorectal cancer coaches will be staying with us live as we close out our live sessions and CRAN's My Colorectal Cancer Summit 2026 public agenda. And then we will head back for our question period with Dr. Adams immediately after. I will share my screen now, and we will continue on as we close out. Okay, as we love to do, and as is certainly tradition, we love to close out with a powerful quote. And this is from the one and only Gandhi. The best way to find yourself is to lose yourself in the service of others. I don't personally think that there is a better way to describe the heart of my colorectal cancer coach program. I think that all of these amazing coaches here live this every single day and do their best to support and to be, to do their best to be in service of others. So I thank you all. Before I pass over to the one and only Philomena, I wanted to take a moment very quickly on behalf of all of us coaches, patients, and caregivers. Philomena, thank you personally for your caregiver drive. You've created an environment for all of us to be able to support this amazing cancer community, and it means the world to us. So we sincerely thank you for your vision, your determination, and for this opportunity to empower not only ourselves, but others. So, Philomena, it is a tremendous honor to pass the virtual floor to you.
Thanks very much, Christopher. That means a great deal to me. It truly does. And thank you, ladies and gentlemen, for having joined today. CRAN is hugely appreciative of your engagement. Our goal was to try to make all sessions this week particularly relevant to the patient, regardless of where the patient finds themselves in the trajectory of the disease. I'd like to take a moment to thank our experts who took time out of their insanely busy schedules to join us to deliver riveting content to help train and educate our cancer coaches so they can guide patients and caregivers through screening, diagnosis, treatment, and survivorship. Our experts empower our coaches, who in turn empower our patients and caregivers to better cope with their cancer, gain a better sense of control, to equip them with the outlook that life is more meaningful when you have acquired that sense of control. So I humbly thank our experts for having participated in the past 5 days. I'd like to thank you, our colorectal cancer community, for having joined our summit. I truly hope you found the summit helpful. Everything we do at CRAN is for our patient community. I sincerely hope you derived comfort, confidence, and competence from the sessions to allow you to continue to navigate this new norm in your life. And if you should have any questions or comments, do not hesitate to reach out, to contact us, for it would be our privilege to address those queries. To our cancer coaches, we are extremely proud and thankful of the dedication and commitment you espouse. It requires a rather special and unique human to give of themselves so selflessly and unconditionally in service to others who are afflicted with a life-altering and often life-threatening illness. And you all, my friends, you do that in such a caring manner when you respond to colorectal cancer queries by compassionately supporting and educating patients or their caregivers. You serve as that beacon of hope and light for patients who are undergoing a tumultuous storm amidst a roaring sea wherein they find it so difficult to navigate on their own. But you serve as their compass amidst that darkness and profound sorrow. I cannot thank you enough for doing this work, because I know firsthand how emotionally draining it can be and how triggering it can also be to assume this role and work. I thank you abundantly for your leadership and love for your fellow humans. A huge vote of gratitude to our event sponsors who have generously supported our summit: Natera, Pfizer, Taiho, and Masters Insurance. Without their support, we at CRAN would not have been permitted to host this critically important event to train and certify our coaches or educate our colorectal cancer community. I thank you, our sponsors, for your unwavering support of our good work. And finally, to my team members who have worked so tirelessly and long on bringing this summit to fruition. Thank you, Himanshi, Chris, Alyssa, Trisha, Cassandra, Kushbu, Maytal. I am so blessed to have you all. Congratulations on having delivered on another superb event. Till next time, my friends, I wish you all well. Godspeed.